We undertook this project because it was time to advance the diagnosis and the classification of rosacea. There have been many advancements in treatment of this condition that really the old measures in terms of diagnosis and subtyping classification did not adequately fulfill. So it was time to progress and move forward. The way we undertook the methodology of this project was to convene a group of experts around the world so that it was no longer simply a regional group of experts, but a global group of experts. And these experts encompass both skin disease as well as ocular disease, because we wanted to ensure that ocular rosacea was also appropriately represented. They were asked to undertake a survey consensus method called the Delphi process, where it was done online, and then any of the elements that were still uncertain were further discussed and then voted upon in a live meeting. The main findings of this project were the following. The first was that the diagnosis of rosacea needed to be updated. So what we had then reached consensus upon is two primary diagnostic criteria. The first is central facial erythema with periodic exacerbation by trigger factors, and the second was phyma, each of which individually could be diagnostic of rosacea. We also had developed a group of major diagnostic features, two of which could be diagnostic of rosacea, any two, and then minor criteria which were not essential for the diagnosis of rosacea but could be accompanying any of the diagnostic or major criteria. The other part of this project, beyond the diagnosis, was to move towards further clarification of current treatment based on current levels of evidence. So we had developed a globally derived measure of different treatments for different phenotypes, which is different than the prior classification of subtyping. So it's a very phenotype-led approach, specifically looking at treatments that were evidence-based, and where there was no evidence, we tried to develop consensus upon which to target treatments appropriate to that phenotypical feature. The relevance of this project to clinicians and their patients is that it keeps the patient at the focus of the condition, as opposed to the subtype, which was previously the focus of the condition. In this situation, we focus then on the presenting phenotypes that are important to that patient, plus of a certain level of severity that the clinician can determine, and also what bothers the patient the most. So there is no need for the multiple dimensions of subtyping. There is now a much more individualistic, holistic approach to the patient when they present. This approach can very likely improve patient dialogue and communication with regard to what bothers them the most, because that's how patients will present. They won't present saying that I'm bothered by my background erythema and papules and pustules, i.e. I'm bothered by my papulopustular subtype 2. They will likely say, I'm especially bothered by my pimples, or I'm especially bothered by my flushing, or especially bothered by my redness, which I look embarrassed all the time. So we can target then those aspects that are most bothersome to them.